Thank you for inviting me to talk about NASH and NAFLD in HIV-infected patients. It's quite a hype at this moment in HIV-related care, so I will give you some background regarding this subject. I have nothing to disclose, and this is just an overview of 4 papers that have been published recent 2 years. And as you can see, we like storms: a gathering storm, a perfect storm, the next big thing, underappreciated, understudied. So there is a lot of attention for NAFLD in HIV-infected patients. And this was, I want to give you first some insight about HIV, because I think it's important to understand why the mechanisms might be different from the general population. The HIV pandemic started in the early 80s. With a report of 5 gay men who acquired pneumocystis jirovecii pneumonia in Los Angeles, and that was the starting point of the HIV pandemic. Currently, 40 million people are living with HIV, so it's a large burden. But there have been some changes in the treatment and the natural course of HIV at this moment. Until the mid-90s, we didn't have much effective drugs, but since the mid-90s, we have triple therapy, and HIV-infected patients can reach a normal life expectancy, and therefore the focus is more on comorbidity rather than opportunistic infections or age-related malignancies. So in our outpatient clinic, we don't talk about bad immunological recovery. We talk about cardiovascular disease, bone disease, renal disease. So there have been changes around there. And the therapies are getting easier every year. Most of our patients are treated with single tablet regimens, so 3 drugs in one pill, once a day, and not the large burdens of pills they used to use in the 90s. And we are shifting from the triple therapy to dual therapy again, with highly effective drugs. I will give you some background on the available drugs in HIV, because that's important for the development of NAFLD and NASH. The HIV virus uses the enzyme reverse transcriptase of reverse transcriptase to replicate, and therefore our drugs are targeted on that specific enzyme. Every HIV-infected patient is treated with triple therapy. Most are treated with triple therapy, and 2 of those drugs are the nucleoside reverse transcriptase inhibitors. There are a lot available, there have been a lot available, but it's getting more targeted. And what we're now using is especially tenofovir, which you might know from hepatitis B treatments, abacavir, lamivudine, and tricitabine. And in the early days, we had also zidovudine, stavudine, and didanosine, but we're not using that anymore, but it's important in the development of NAFLD. Besides the dual therapy, we started a 3rd drug that might be a non-nucleoside reverse transcriptase inhibitor, not used very commonly, but still in use in a lot of patients. We use the protease inhibitors. Protease inhibitors prevents the virus from cutting the proteins and forming a virion. And the most commonly used protease inhibitor is darunavir, but ritonavir is also a much used antiretroviral drug. We have some entry inhibitors. We don't use that much. Maraviroc is an example. It targets the CCR5 receptor on the CD4 cell, and that might be relevant in the treatment of fibrosis in the liver. And the current most chosen backbone are the integrase inhibitors. That's the first choice of therapy. So most patients use 2 NRTIs and an integrase inhibitor like dolutegravir, bictegravir, raltegravir. In 2017, this meta-analysis was published, and it gained a lot of attention. It has not such a dramatic title as the early mentioned articles, but it describes a high prevalence of NAFLD in the HIV-positive population, with numbers up to 35%. But that's based on only 4 or 5 studies, not very large studies. And in this study, they stated from the prevalence of NAFLD in HIV-infected patients is higher than in the general population, and they refer to all kinds of studies who report the number of 25%, but head-to-head comparisons are performed in just 2 studies. I will show you later. The risk factors we identify for NAFLD in HIV-infected patients are much the same as in the general population. So high BMI, hypertension, high triglycerides. The only HIV factor is the high CD4 count. The CD4 count is the degree of immunological recovery, and it marks that patients are not severely immunocompromised, so they're much like the general population. There are 2 head-to-head comparisons in some way. In 2014, the group of Price published a study which included 700 patients who were in a clinical trial for HIV drugs and underwent CT scan and were diagnosed with steatosis or NAFLD based on the CT scan. Unfortunately, they excluded all patients with cardiovascular disease. So that might be a bias in this study, and they found that the prevalence of NAFLD in HIV-infected patients was indeed lower than in the general population in which it was compared to. So that's remarkable considering the earlier reports, and they showed also an association with certain genetic factors and also the use of the so-called D drugs. I will refer to that later. And more recently, Kardashian et al. Performed an MRI-based study, including 200 study subjects. And in women living with HIV, there was a lower incidence of lower prevalence of NAFLD compared to the unaffected women. In the men, there was a higher prevalence, but this difference was not statistically significant. I want to talk about 2 major factors in HIV. There are a lot of more factors. Alcohol use is extensive in HIV-infected patients. The microbiome is also very important. Hepatitis C genotype 3 co-infection and the genetics. But the 2 hallmarks I want to talk about is insulin resistance and mitochondrial toxicity, because that's more HIV specific, I think, than the other factors. Well, was it already a problem, NAFLD in HIV-infected patients in the early 80s when we didn't have treatment? Well, nobody really cared because patients were dying from opportunistic infections and malignancies. But a small autopsy study revealed that 60% of the untreated HIV-infected patients had some degree of steatosis. That might also be due to liver infiltration of infections, but it's remarkable to see that it was such a high degree. And some groups suggest HIV has a steatogenic effect on the liver itself. But I think the most important is that HIV provokes a very great inflammatory response. So you see a lot of immune activation in HIV. Much larger than in an uninfected population. And this brings up also insulin resistance. So that's probably the big reason why we see so much NAFLD in HIV. Is that still a problem? There's a lot of discussion because we have safe drugs. You can reach virological suppression, you can suppress the virus, and there is a lot of debate in HIV-related care whether this immune activation is still present. You find some higher rates. You have some believers, you have some non-believers. And in general, it's believed that the degree of immune activation is so low that that might not provoke significant insulin resistance. But it remains a point of discussion. Of course, we also cause problems with our drugs. It was mentioned in 2 talks earlier, the HIV antiretroviral drugs may cause also insulin resistance. And we're most feared of about the early generation protease inhibitors. They were introduced in the mid-90s, and 2 of the protease inhibitors induce some kind of insulin resistance. And they do that by blocking the GLUT4 receptor. one of the drugs we're still using, ritonavir. We don't use it as an antiretroviral drug itself, but we use it as a pharmacological booster to boost the other drugs. So it's given in a low dose, so you won't expect that much effect, but we're still using it. And the other drug that was associated with insulin resistance was indinavir, but we don't use that because it caused kidney stones and remarkable also ingrown toenails. I was quite surprised about this article. But we're shifting towards a normal population at this moment with HIV patients. They're getting older, they gain more weight. And in this study of 2010 from the US, it was illustrated at what point HIV patients started with antiretroviral therapy. And as you can see, the degree of obesity in this population is increasing, and patients are starting at a higher BMI with the therapy. So they're much representing the general population in that sense. Another hot topic in HIV care at this moment is weight gain. We see weight gain in all drugs, and it was generally considered as some return to health effect. So people lost a lot of weight because of the HIV infection, and then they were started off antiretroviral therapy, and then they returned to their normal weight. But the last big conference, there was a lot of discussion about the integrase inhibitors, which are the most common used backbone at this moment, because some groups suggested that in the integrase inhibitors, in INSTI, you saw more weight gain compared to the other drugs, the NRTIs and the protease inhibitors. And when looking into the integrase inhibitors, there was certainly an association with dolutegravir in the upper line, rather than elvitegravir, which is much less used. So at this moment, that's the big subject on HIV congresses, and we're still not sure whether the integrase inhibitors do cause an increase in weight. We found some subgroups, especially African women, seem to be at risk for increased weight gain. So we want to withhold the therapy for them. We choose a protease inhibitor or an NRTI, but it's not very clear what we should do with this. So we still looking into that. Besides the insulin resistance, I think the most important other factor is mitochondrial dysfunction. When you look into HIV-related NAFLD, and it's especially associated with the early generation NRTIs. That is stavudine, didanosine, and dalcitabine. There are used the D drugs, and except for didanosine, none of these are still on the market. But a lot of people were exposed to these drugs because that was the only thing that was available at that point. And we still see the problems of the former use of this medication. And it tackles on the mitochondrial in a certain ways. It has a high affinity to bind to the polymerase gamma in the mitochondria, and therefore the respiratory chain doesn't function that well. You get reactive oxygen species. You see depletion of the mitochondria in certain tissues, and for example, in the peripheral subcutaneous fat tissue, you saw this happen. People got small cheeks. That was something we observed just after the start of the triple therapy. And this was caused by the drugs like stavudine, sidofudine, and didanosine. And it caused mitochondrial depletion, and therefore there was apoptosis of the fat tissue. And people got redistribution of their fat. The fat distributed towards their liver, towards their abdomen, and they had very small cheeks and very small arms. And this lipodystrophy syndrome was also associated with marked insulin resistance and high triglycerides. You can see this in two different ways. You have some acute presentation of mitochondrial dysfunction that was described in 1993. Then you saw hepatomegaly, lactate acidosis, but we also see the long-term effects. When we're going to check for the HIV-infected patient with liver problems, you see that these patients had increasingly had a higher rate of didosine use in the past. So even if you use it in the past, there is still some fibrosis. It doesn't reverse. So those people are at risk for liver fibrosis and cirrhosis, and we see those problems every day. The people who used to get this treatment. The current treatment doesn't cause this mitochondrial toxicity, but it's an important hallmark of the older therapy. Not only in the adipose tissue, but also in the liver, the mitochondrial dysfunction causes problems. The oxidation of the fatty acids is diminished, and therefore there is lipid accumulation in the liver, presenting as steatosis. Well, the treatment for NAFLD in HIV-infected patients is not so different from the general population. Of course, weight loss is one of the most important issues. Furthermore, you want to diminish the degree of immune activation, so we start treatment as soon as the diagnosis of HIV is established. We have combination antiretroviral therapy that has a favorable metabolic profile compared to the early generation drugs, and hepatitis C cure might also attribute to diminishing the degree of to steatosis. The etiology of HIV-related NAFLD is not so much different from the general population, but there are some things you have to take into account when you start these people on drugs. They're using antiretroviral drugs will have a lot of interactions with other medication. For example, when using a protease inhibitor like ritonavir, you see induction of the CYP3A4, and that might also cause alterations in the therapy for NAFLD. And therefore, these patients are not represented in the clinical trials at this moment for the NAFLD therapy, and that's remarkable considering the high prevalence of NAFLD in HIV. There are some drugs in research for HIV. And NAFLD, tesamorelin, is a growth receptor hormone analog who was originally used in HIV, but was now also introduced in the treatment of NAFLD. And it showed some good endpoints regarding diminishing in hepatic fat when assessed with liver biopsy and MRI-based studies. We also see a decrease in progression towards fibrosis when compared to placebo. But it was only a small study, so more studies have to follow to establish this effect. And most of these patients didn't have fibrosis at the starting point of the study. And this is also quite an exciting possibility. CVC was originally invented for HIV. It blocks the CCR5 receptor, who is at the CD4 positive lymphocytes. And we're currently using maraviroc, therefore, but CVC was developed but didn't get through for some reason, but now we're using it in the treatment as an anti-fibrotic agent. And by blocking the CCR5 and the CCR2 receptor, we also block the stellar cell, which is an important cell in the development of fibrosis. Two studies have been performed, one in HIV-infected patients, and we saw that the biomarkers in The patients treated with CVC were lower compared to people who received placebo. And in another trial that didn't include HIV-infected patients, we saw less progression of liver fibrosis to some degree. It was published in Hepatology in May 2018. So some take-home messages. NAFLD is common in HIV-infected patients, but we don't really know whether it's more prevalent than in the general population. There's a common pathway, but the etiology might be different, the drugs might be different, and we're shifting towards more general population risk factors rather than the old drugs we used, but we don't use it anymore. So that might not cause this high prevalence. We should be aware that people who used didanosine or stavudine in the past are still at risk for liver fibrosis. So people diagnosed in the 80s and the 90s with HIV might have received this treatment and are at risk for NAFLD. And it's a pity that HIV-infected patients are underrepresented in the current clinical trials. That was my presentation.